Okay, can you hear me now?
Yeah, I can hear you, Prof, but
It's clear?
yeah, it needs to be louder a little.
Hello? Can hear you very well. Hi, Carole. Hi, how are you?
I'm good. How are you?
Very good. Thank you so much. I think it's too early for you, huh? In Texas.
It is early for me.
Yeah, 6 o'clock, maybe, or
You're a little soft. Can you?
yeah, it is 6 o'clock in your time.
It's 4 o'clock my time.
Oh, so that's too early.
It's
Very
very
good.
early.
Dark, huh? Susan.
Okay, Prof, Muhi, we can start.
Okay, thank you so much, Carole, for joining us today. It is our pleasure. And thanks for everybody who is attending our webinar today. And we are really very pleased and privileged to have Dr. Carole Cooper. She's an Associate Dean for Research, School of Health Professions, University of Texas Medical Branch at Galveston. She also served as the director of the UTMB Center on Health Promotion, Performance, and Rehabilitation Research, and chair of the Department of Physical Therapy and Rehabilitation Sciences. Her education includes degree in physical therapy, electrical engineering, and exercise science. Wow, this is really very multidisciplinary, from engineering to science to exercise. Dr. Trucker's research interests include rehabilitation, digital health technology, health informatics, measurement sciences, patient-reported health outcomes, and application of AI, which is really our topic today in healthcare and lifespan health, particularly in pediatrics. So objectives of this seminar is really to understand the components and construct underlying artificial intelligence and understand the evolution of AI and its impact on healthcare, as well as other objectives which will be covered in this webinar. Now, I think everybody is eager really to listen to Carole for this really very hot topic of the time.
Thank you for that kind introduction. And good morning or good afternoon to everyone. I am going to share my screen and then we can get started. Can people hear me?
Yeah.
Yes, yes.
Okay,
Dr.
super.
Go
I
ahead.
just wanted to make sure. All right. I'm gonna ask just so that I can help keep track of the questions, if you could put your questions either in the Q&A so that when we're done, I can come back to those and we can have a really lively discussion. And the chat, I'll probably just continue to go through the slides until we do that. So first, I'm really delighted to speak on this topic. It's something that has such an impact on us and it's changing every day. And I know that I expect there's going to be a lot of passion about where and what we should be doing in education, practice, and research. So, sorry, let me advance. I do want to acknowledge, I really have my start, even though I've been involved with AI since the 1980s. The cycling up and the gathering of healthcare practitioners really started with our medical associations, our physicians. And the Global Forum on Innovation in Health Profession has done a series of workshops, and the National Academies has also done a series of free publications that can be downloaded from their website that are quite comprehensive. So just in terms of understanding perhaps where we're going as healthcare practitioners and what we're thinking, those are two good resources, and I'll mention them later. I always start out by mentioning three things, and for me, it is 4 o'clock in the morning. And if if I was attending this this early, I'd probably want to make sure that you get these three things. And we're going to talk a little bit about AI and maybe demystify what it means and what's AI and generative AI. But really, the key for what we're seeing in this evolution right now and this uptick and questionable ethics and sources and bias, and it's not clinical reasoning, is really the data sources. So we will spend some time really looking at the current data sources that could be available for us to use, whether it's in teaching or whether it's in quality improvement in our clinical practice or our research. But that, to me, is what really has jump-started, kick-started the AI, as well as the large language models. But the one thing I worry about as soon as someone said, I used AI to do X, Y, or Z, is not quite so much what technique did you use. It's actually what data sources were embedded in your generation of knowledge, if you will. I think the second point that really needs to be strongly made, and it doesn't matter whether it's you're a student or a professor or a clinician or somewhere in between, we need to be at the table. Right now, a lot of the applications of AI are being dreamed up by the technologists. So if we are not there, if we're not telling them what our concerns are, what we need for clinical reasoning, where we need AI to really benefit us, then I think we're really missing an opportunity to help shape the emergence of it. And then finally, we need to step out of our role and of just providing healthcare. We need to learn to be experts in what I'll refer to as non-technical AI. I think when we look at a lot of the offerings in AI, although they're changing now, the expectation is that we're going to make people be able to program AI algorithms. If you look up an AI course, it's like everybody needs to learn Python or one of the other languages. And that's just not the case anymore. We need to be fluent in the application of it. We all don't have to be the engineers, but we all need to understand the application and the nuances in it. So those are three large take-home messages that I just want to make sure that people really, from the very beginning of this talk, kind of understand the importance. So I just want to frame this a little bit from a historical perspective. We have seen these major transformations since society really has had a recorded record. And if we look back in the mid-1700s, we had the concept of railroads, steam power, mechanical production, things moving beyond handcrafted. And that really changed our commerce system. It changed the way we utilized. And there was, just like we see now, a fair amount of fear, if you will, about what that transformation will bring. The second really was looking at mass production, electrical power, assembly lines. And again, people feared there that we would be replaced. And at some level, maybe we have. The third happened in the 1950s. You can see they're almost accelerating faster now, also, by the way. And we saw electronics and computers. This is really when AI first emerged. We need computer power for these AI algorithms to run. The fourth revolution, which is labeled now, as you can see, I had to modify this graphic, is really when we saw big data, access to big data, robotics. It's when AI really became more commonplace. And finally, if you've looked at the news just in the last week or so, they've talked about how we've now hit the fifth transformation. And it really is referred to as a cognitive transformation. It's impacting not so much how we do things or maybe how we move in the environment, but it really is impacting the way that we gather information, the way that we put information together. It really is this cognitive transformation. What we do know about these industrial or revolutions or transformations is that there's always a fear of what will be lost. But as you notice, we really don't go back and prevent any of these transformations. Just as an example, I had mentioned that back before we really had mechanical production, a lot of things were handcrafted. When we look at assembly lines, a lot of our cars, for instance, our major appliances are made on an assembly line. It doesn't mean that we don't use them. Those have become such key components of our day-to-day life, things that we just use. On the other hand, if you want something handcrafted, if you want something unique, if you want something that you might consider of more personal value, those routes to get those are still quite accessible. And so I don't think we should be afraid of this transformation. We're not going to stop it. It's going to have a lot of good. And I think it really comes back to my second point of us being at the table, and my third point of us really understanding what this transformation is doing. So I started my training as a physical therapist. I moved into getting my degree in electrical engineering with my large focus actually on AI, signal processing, looking at data. And this was back in the late 1980s. My PhD is a combination of electrical engineering and exercise science. So I actually used artificial neural networks to parse through gait analysis data and to try to make sense of some of the changes we were seeing in muscle coordinative strategies. So for me, AI has been a tool I have used all along. Approaching this from kind of this information science lens, we all often think about this transformation of data to wisdom. And when we think about where AI could have a place in our current use and generation of knowledge, be it within our professions or daily lives, I think this is where we need to consider the beneficence, the goodness of AI, and where maybe we need to make sure that we're heard and that we have a larger role. So data really is anything that we pick up by our, what I'll call our sensory transducers, right? They're just random bits and pieces of data. So it could be the sensation, it could be things that the light, the environment, the task, proprioception, any of those things. Out in the real world, it could be the random pieces of things that we see or data that's available within papers or networks. So there's not really any sense of organization in the data. We move from data to information when we talk about information science, when there's a structure added to that data. So the data may be categorized into categories. Well, that makes sense. Into piles. It may be sorted. It may be connected. That's where we start to make sense of the data. It's not just bits, but they actually have some logical ordering. But still, that's a lower level on this information process. When we move up to knowledge, that's where we really, in my opinion, as healthcare practitioners, start to add value to the data, right? So you may have a series of lab test results. They may be organized into your metabolic panels. It may be organized into your complete blood counts, but it's really the interpretation of that. What's normal, what's not normal, how do these relate to each other? That's where we see knowledge. And I think as we operate and what we're trying to teach ourselves and our students is that knowledge piece, right? We call it clinical reasoning, putting bits of information together so that a more complete, richer picture emerge. And I think where we see AI having huge benefit is this data to information transition. What we're seeing generative AI do in some ways, in many ways, is moving us from information to knowledge, making some of those connections for us. But the top of that pyramid, that wisdom, really is, when you say somebody has good intuition, or they really came up with the right diagnosis, or wow, that physical therapist really could tell exactly what that patient needed to have them get better, to have value out of their current intervention, how it needs to be changed or adjusted. That's that knowledge to wisdom. And just like anybody, that adds maybe what judgment may be a strong word, But anybody that uses knowledge and kind of maps that higher level cognitive processing onto it is at risk of bias. This is where we may disagree. I may look at the knowledge presented to me and say, I think it indicates A. And one of you may say, well, I feel strongly that it's B. And some of those are our life experiences, things that we have seen before, and all of that. We're starting to see AI, and it depends on the data set that it's working with, feel like when it makes these pronouncements, for those of you that use ChatGPT, comes up with these summaries that all of a sudden sound really wise, like they put things together. But what they're putting together really is opinions that other people have already put together in long term. And to me, that's not quite wisdom. Wisdom does require humans. And I'm not quite as fearful of AI ever replacing the wisdom that I could generate from information, or that any of you could generate from information, in the same way I think we're seeing it in the news now. So I just want to come back and demystify a little bit about what artificial intelligence is. So when we looked at those transformations, you saw that back, even as early in the 1950s, the 1970s. So I guess that's about 50, 60 years ago. People were already looking at computer power and perceptrons. So in 1958, long time ago, for many of us, they first came up with this idea of an artificial neural network. You heard, mind thinking, brains, people started to get nervous about it. There was a specific programming language called Lisp, which was really used. The neat thing about Lisp, and in the pictures I'll go through, is that AI is really based on a very simple decision paradigm. It's things are off or on, things are and, like in logic, or they may be or. It's A or B, A and B, A not B. And with those just simple pieces of logic, a lot of those pieces of logic, if you will, you're able to start to generate patterns and all of that. So, of course, back in the 1960s, what did they do? They thought, well, we know that synapses now are either on or off, right? So it's this one threshold. You have your action potential or you don't, your membrane potential, you fire or you don't. That synapse is actually connected or it's not, fire and wire. We're familiar with this as medical professions. We're taught this early on. The individuals, the engineers, looked at their transistors, and transistors, even nowadays, for the most part, are either on or off. And so it came up that if we would put enough transistors, and they were little physical pieces, they still are, if we can put enough of them together and use this logic language, which is what Lisp is, then all of a sudden we could actually make a brain. And so that really, this picture over to the right, you may look at it and think, oh, that looks a lot like what I would draw, a neuron and synapses, maybe spinal cord and cerebellum, however you want to view that. That actually is what is a perceptron. That's a neural network. And so it has a whole lot of inputs. It makes connections with them. It may go through an intermediate kind of, if you want to think about it as a cortical structure, and then out comes a decision. And so AI is really based on the concept of a lot of very simple logic units strung together, much as our brain is firing on and off. Nothing mystical about the basic thought process, if you want to call it a thought process, in AI. And here's a classic. We see these nowadays actually being used. This is an artificial neural network in ANN. It's called a feed-forward backpropagation. And so when you think about the way that if you look at your motor programs, for those of you that know your motor control, it's this concept of feeding back within a structure of neurons that are in different layers in order to make decisions and to refine a motor program. So in this case, and this is example of the inputs, I didn't pick anything medical, are soil and climate parameters. And then the output is what might be the appropriate crop to grow at that point in time. So let me take a minute to walk you through this. So whoever designed this artificial neural network decided that the correct inputs to it are things like texture, slope, erosion, all of these things. So this is what their decision is based on. If the color of shirts the farmers wore, or if it was, how was it going to be pulled out of the field, you would have different outputs, right? Or they may not be the same output. So again, this concept of what is the data set for the input is incredibly valuable. So each of these are entered, just think about long lists of numbers and then repeated columns with different values for each of those input categories. If you have between the input and whatever you're trying to decide it, and in this case, if this was trained, and there are different training algorithms, but it may have been told there are 4 outputs and that it then goes back and labels these. These connections are all weights. So they may start out saying multiply the depth by 1, the drainage by 1, erosion by 1, connected to each of these first layer neurons, and that's processed. And then connect these to the second layer and then to the output. With these 2, what are called hidden layers, you can actually categorize things in nonlinear fashions. You can make really complex sense of it. Do I know exactly how the weights are derived? And this is where we often hear the black box. No, but there are now algorithms that kind of let you see that. So what happens is I put in this massive data set of inputs. I have it feed through. In a supervised learning, I would know what the correct outputs for each set of inputs is. If it wasn't correct, I would then, like we feed back sensory information, I would feed back that information and it trains. It goes back and forth and adjusts these weights until it gets the least error in the categories. So that's an example of supervised learning. Nothing frightening about that. These weights are adjusted between 0 and 1. So again, something that's kind of either on or not on, and it can really separate data into categories. I could use it unsupervised learning, where I have a similar structure, and I may just say, put it in 4 piles. I'm not going to tell you what the 4 piles are. I'm not going to check for errors. I'm just going to look at the end and see if you came up with the same expectation that I would, or if there's something different about this data set that really, it may not be these 4. They may be blended, and let's see where that goes. So there's a whole lot of different ways that you can use these networks. They're incredibly powerful. And they're based on, one of the most powerful computing tools we have, which is our brain. What's neat to me about this is that when we see generative AI, you can think about it that these aren't told maybe how many outputs there are. It's just told, put these in as many piles as needed with some characteristics. So it's actually modifying that final row. It may not have 4 outputs. It may only have 3 clusters. It may have 6. Again, it should sound like factor analysis to you, or exploratory factor analysis. So again, nothing terribly frightening about this. Here's an example of things that neural networks can separate using that simple logic. To me, this looks like there may be no separation. I actually don't think there is. So a neural network may come back and say, this data doesn't make sense based on location, but I could categorize it maybe by color in another dimension. Here's color dots, again, random data I picked for you, that, this is your data. This now becomes the next step up its information. It's categorized. These are linear separable boundaries, very simple, very obvious. We're all sitting here going, well, Carole, I probably could have drawn those boundaries in, and you're absolutely right. But it's doing it automatically, and it may be doing it on a data set of 1 million data points. So something that it would take any of us a really long time to do, it can do fairly quickly. And I should add that once a neural network is trained on that input data, those weights are then kept static, right? Just like you have a motor program in your brain and you may continue to use it, we often continually update it as needed with new experiences, but a neural network you can train and then just deploy it really quickly to do this separation, to do this making the data into information. The final one actually would be, even with those 2 layers, it could draw boundaries that really separate very complex boundaries. So again, simple units, a whole lot of it, a really good data set that makes sense, and then you have a tool that can be used to classify. Training can take a good bit of time. For my PhD, I often, again, this was back in the 1990s, I would probably start up 6 or 7 different PCs before I left at night. And then some might take days to really go through these large, complex data sets. And so, you know, it wasn't for the faint-hearted. At any rate, it's just math. It's just logic. So to take a little bit of a step back now, that hopefully you realize that AI, you know, operates on bigness. We do have AI. It was really the first to emerge from there. And that really is programs that learn and reason like humans. We've seen machine learning. It's a subset of AI technically. It's algorithms that can learn without being explicitly programmed. So that's where part of that, how many trees, so a random forest, how many clusters, those types of things, where I may be less clear on what the output I need is, or the form of the output, and it does some of that for me. And then we have deep learning, and we're starting to see this emerge. And this is really even a smaller subset of AI within machine learning. And it's when we start to use the artificial neural networks to do that, and we're learning from vast amounts of data. To me, I probably go right to deep learning. Every time I think of AI, I think of deep learning operating on these large data sets. But at any rate, that's kind of the terminology we see used. But I want to bring your attention to the right side of the figure. And here you can see we have machine learning. We have learning. I talked about supervised learning, right? Where you kind of tell it what the beginning and the end is. We have unsupervised, where you give it the input, but you kind of either let it cluster or reduce the amount you're sorting through, dimensionality reduction. And then there's a thing called reinforcement learning, which I won't go into today, but those are the 3 classic types of way we train these algorithms to turn into classifiers, right? Once they're trained, the weights can stay stable. They'll continue to classify. But when you look out at these final terminal branches for these, you'll start to see things that sound like statistics. The networks we've talked about, this artificial neural network, feed-forward back propagation, a lot of the clustering, do statistical pattern recognition. So based on some statistical characteristics of the data is how they group it. So you see here, we have clustering, k-means of clustering, decision trees, linear regression, logistic regression, principal component analysis, factor analysis, all of these things. None of these are particularly scary, right? You guys have learned these in your statistics classes, or you will, or you may not. But at any rate, our statisticians are quite familiar with this. And artificial neural networks, machine learning, deep learning are just a way to get at these faster. And so again, nothing scary about it. I want to just give pause here for a minute to bring up kind of another analogy about things that do math. You know, when I was in elementary school, and I think still our elementary kids learn to do math paper and pencil, right? So what we're trying to teach them are the concepts of what's addition, what's subtraction, what does multiplication look like. maybe what do we mean when we talk about exponential growth? What are exponents? And so we do a lot of this by hand. We know this. When I went to engineering school, this was before the time, certainly, of cell phones, but also really before computers were powerful. And we moved pretty quickly from using to hand calculations to calculators. And this was a big deal. It was like, should we allow people to use calculators on exams? They're going to forget how to do math. Somewhere in between the hand calculation and the using a mechanical or a calculator were slide rules. So we actually had, our foundational intro to engineering course teach us how to use slide rules. I don't think I ever used it beyond that course. But again, it was this concept of using existing tools, being fearful of what's new. From calculators, and all of a sudden there were programmable calculators, right? So now, instead of just being able to do math, we gave them like a long-term memory or a short-term memory, right? They could remember these algorithms, these sorting algorithms, just like we trained a neural network. Our programmable calculators had these little mini routines embedded in them. And then if you move from your handheld calculators to our cell phones nowadays, right? You use the little calculator on there. You may actually use the internet. We'll talk about that to go and figure out your answer. Have people forgotten how to do math? Well, if I hand cash to someone and they put it in the register wrong, many times they can't count the change, right? They struggle with that. You gave me $2, it's only $1.47. How many coins do I need to give back to you? And it's really challenging. Does it interfere with commerce? Does it interfere with my ability to buy things? Not necessarily. Does it make me feel like, is it okay people have forgotten how to do math without mechanical aid or a computational aid? Probably. But on the other hand, it's really moved us forward. And I think as we look at AI, what we have to realize is that we want people to know how to think. We need them to understand what is addition and subtraction and when is it appropriate to use it. But let's face it, these tools are going to do some of that rote, redundant type of calculation for us. We just need to be careful as we climb up that information processing tree. So big data, my first of three things I really need you to remember is really all about the data. And we hear a lot about big data now, and these are extremely large data sets. With paper and pencil, I'd never be able to make sense of it. They are analyzed computationally. We see a lot of this related to human behavior measures and interactions. I do a lot of big data when I'm looking at complex movement patterns. You can tell I do a fair amount of biomechanics. But big data does have a definition, and it's characterized by just this incredible growth at these ever increasing rates. So we're talking about a high volume or amount of data information. We're talking about a high velocity or speed at which that data is created and collected. So maybe collecting muscle activation 1,000 times every single second, you're getting new data points. And then the high variability of information or scope of data. If it's coming in, it's not necessarily going to be clean. You could actually pull in multiple streams of data. I could look at things in the environment. I could look at things that are happening physiologically. I could look at resultant task completion, movement performance. I could include genetic data. I could include lab values. And so big data really is a thing. And it's not just big, it's highly variable. It's changing rapidly. You're really aggregating it fast. But notice again, this is data. This isn't necessarily made into information until you do some form of mathematical, I'll say, operation on it. So we have big data. We're collecting it. It's there. We're able to collect it and get bigger and bigger data sets because of these advancements in technology. And if you remember, this was back really the fourth transformation. And so even though this looks like a really old picture, it probably is, probably from the 50s. When I went into engineering school in the 80s, we didn't have personal computers which looked like this to begin with. We had massive supercomputers, as they were called, that were in rooms, right? So if I wanted to actually go and interact with a computer, it was just beyond the age where any inputs into the computer were on punch cards. We were able to start to type, but I actually had to make an appointment to go in and physically be in a room where the computer was massive. So we've moved from looking at the speed and the size, these were very slow, into microprocessors. So taking all of these little, I'll call them logic units, making them smaller, putting them on chips. They got a little bit faster, but if any of us remember using very old computers, they were really slow. The storage on some of these old computers might have been, 100 megabytes. I'm now carrying thumb drives that are even probably less thick than my thumb that have terabytes of space on them. And so as our technology got better at making these little transistors, these little logic units smaller, packed on a chip, able to keep it cooler, put them in a unit that allows you to visualize and put input in. The storage and memory capacity, and then finally our data access speeds. Even when computers were reasonably sized and priced to fit in homes, we couldn't access this data. This has all happened in the last 50 years. We didn't have cell phones back in the 1980s. People were paged by beepers. I don't know how many of you in the room, because I can't see you, are old enough to remember that we couldn't carry a phone around in our pockets. So when I was on call for the ICU in the evenings, if I left my home phone, as we now refer to them, landlines, to go out and run errands, I had to put change in my pocket because I was going to have to use a payphone. We don't see payphones anymore. So these computers that we now carry in our pockets are really as powerful here. We didn't have a problem really with this transformation. I think we now struggle on being available all the time, trying to put up kind of our responsibility to maybe be at work all the time, to not have people ping us day and night. In the last year, we've started to see phones that you can turn notification. I mean, I think you always could, but we're noticing more people, I think, post-COVID, turning off notifications when they're at home. So again, just something to consider in terms of this transformation's coming. We're not going to change it. We don't want to go back to rooms with computers. We don't want to go back to where we couldn't collect big amounts of data to try to make sense of the world and the people in it. But we have to be careful about how we use it. The final thing that really has moved us into what I'll consider the AI world is access to data. So it was only really in the 1990s that the internet appeared, our ability to connect with other people appeared. And this is where we're all sitting here going, okay, well, you walked us through the handwriting to cell phone calculator. And yeah, we lived through that. There are parts of it that may be a little off-putting. Computers getting bigger and me having a cell phone seemed to be a pretty good thing. There's some issues with that. But then when we start to connect people and computers and we have an internet, this to me is where I think more of us start to have hesitation about, wow, kids being on the computer, the amount, before you would look at your little social network and it may have been the kids in the neighborhood, but now a teen can look throughout the whole world and decide whether they're pretty enough, smart enough, what are other people in the world doing? How should I feel? What should I ask my parents for? We know our students are going on the internet. It's really become a piece of the fabric within our lifestyle. And again, this happened. It really, again, the late 90s, 2000s, before we really had internet connectivity. And 20 years later, we're still struggling with the ethical use. When is it appropriate? Are people able to think? Have an example of us attending a healthcare workshop at a large hospital, and it was about a mile from where most of us were staying in the hotel. So a group of 6 of us were walking back. 3 of us were older, 3 of us were younger, and this was in Ohio, which is in the United States. It was in Columbus. And as we're walking back, somebody said, "Hey, I wonder what the largest city is in Ohio." And so the 3 older people are in the back going, "Well, let's see, Cincinnati is on the water, and there's, this is in Cincinnati, and Columbus has the University of Ohio. It can't be Akron." So we're sitting there pulling together what we know about things. Meanwhile, no surprise to anybody sitting here, the 3 younger people pulled out their phones, looked it up, and came back and said it was Columbus. And I thought, wow, we probably could have pulled out our phone and figured that out, but it was really fun just to sit there and share facts that each of us knew and try to feel like we figured it out on our own. And I think when we start to look at these AI tools and ChatGPT and all of that, what we're really looking at comes back to what's available at some level on the internet or open to everyone, that we can train things to help make sense of the data out in the world. So again, this concept of generative AI and being afraid of losing our clinical reasoning or being replaced or anamorphizing these things so people feel robots are real because they can think will take a while. And there's good and there's kind of scary things about it. So I've made a reference all along about how things have been changing. But what I really want you to see is the rapid rate at which just in the last 10 years we've had, and I know you can't read the headings. If you're really interested in the slide, I'd be more than glad to provide it. Just email me afterwards. But the basic concept is things are changing so fast now that we can't even teach these new algorithms fast enough to the lay people. And so what we really need to do is to take a step back and say, how do you ride a technology wave? What's the strategies? What is the key kind of guts of these things that we need to be concerned about and threats? How do we make wise choices? And this is why we're at the table. What I talked about this week about AI is slightly different than what I talked about last week. And it's certainly different than maybe the AI talk we did 3 or 4 months ago. And so the technology and the tools we may discuss specifically are rapidly changing. But what's not changing is this reliance on perhaps biased data sets. Who's using it? What are we replacing? Is it ethical to replace it? How do we prevent students from writing with it and retaining skills? It's kind of all of the, if you will, all of the above. That's scary. So I'm not going to teach you an individual tool today because next week it'll probably be out of vogue. If you use ChatGPT this week, if they release a new training on a data set, that's what they do when they update it. They retraining it on a larger data set, and then they release it. So the prompt I used last week on ChatGPT may yield a different answer this week if it's across one of these re-release of that model, if you will. And so just keep that in mind. It's really about understanding kind of the underlying training, what it was trained on, where it's going, and all of the above. So for natural language processing, I want to address this because what's really brought AI to our attention, like I said, it's been there forever, is they moved from applying it to numbers only, which is really what I've been focusing on, to things that are written, right? And so you start looking then at this computer science and what we know about linguistics. It's giving the computers the ability to support and manipulate speech and reading and writing, and that's referred to as natural language data sets. So again, they could be trained and look at statistical difference, the relational difference in words, using machine learning. And this in some ways has really been super brilliant in terms of the tools that it will allow us to do. So we now are at the point where language understanding, both reading and generating text, is really pretty commonplace. Again, just in the last 10 years. But we were able to recognize handwriting, recognize speech. You remember all of those little apps that will transcribe what I say? That's recognizing speech. Image recognition is certainly doing that. We look at all the face recognition algorithms and things like that that we see out there. And what really has changed in the last year or two is our ability to understand languages. In this graph, it gives you that timeline. But if you look at the vertical axis, 0 is human performance on a benchmark test of one of these algorithms, so language understanding. And what you can see since about 2018, that AI systems may perform better than humans who did these tasks. And I think, this to me still isn't scary. I can tell you my calculator can do math much faster than I can. So it might always get the right answer. And I may not, but again, it's just something to think about. These tools are coming on that lower part of the pyramid between data and information. So let's walk through natural language processing a little bit. So here is a linguistic map of functional language use. And you can see that, at the top, we have ideology. So it's a little bit kind of a corollary to the wisdom at the top, right? We have down at the bottom, the bits and pieces. So things like words and letters. I know when I learned language in elementary school, we diagram sentences. Here's the noun, here's the verb, here's the adjective. How do these play off with all of the diagonal lines? Very proud of ourselves when we can do that. These languages and words are put together to be text. So that's moving from kind of the data, if you will, to information. And then you can see cultural and social context are mapped onto it. So there's still the same process of moving up in our understanding of this. And now it's just applied to language. And so the input data may now be frequency spectrogram. If you're trying to look at my speech and transcribing it, the word sequence, those can be moved into speech recognition, and what the output or the input, what it may be trained on, is looking at frequency of different sounds. And there's kind of this massive dictionary of how frequency of different sounds are speech. Again, things like sentence structure, what comes before, what comes after, what's partial meaning, what's the sentence meaning. These are all the types of things. These are your addition, subtraction, if you want to think about it, that it can do. This really is what natural language is. And so again, this simple processing of combining relatively simple elements into groups, adding meaning to it, and then using it. So that's natural language processing. I'm going to spend some time talking about ChatGPT, but again, the data sources that are used in natural language processing, those input data sets, are massively important. So if we look, a common use now is going into an electronic health record, and all of those notes that in the olden days we hand wrote or now we're typing in that aren't discrete data elements weren't really available for use in big data analysis. So if it wasn't a lab value, if it wasn't a drug at a specific dosage, they all have standardized vocabularies, it wasn't making it into our big data sets of EHR data. We're just now starting to see natural language processing work well enough that clinical notes, so those PDFs, are being parsed into usable knowledge. The other source of data that we're seeing is this massive scraping of social media data. So, we've always heard, if you put it in an email, it's available at some point, assume somebody's going to see it. These natural language processing bots, algorithms, ChatGPT are going out and just saying, go, basically anything that's out there. You could take web things, you could take reactions, you could take Yelp reviews, you could do X and Y. Apparently you can't take New York Times articles because they felt that was proprietary. But again, all of these things, books, newspapers, manuals, transcripts. So when our students use something like ChatGPT to learn medical knowledge or clinical reasoning, it may not just be from our electronic health records. ChatGPT operates on all, well, not all, but as many public data sources as it can. And I'll walk through a few models that actually, in a few ways, that the newer ChatGPTs will let you limit your data set for that input knowledge. Those are the types of tools we as healthcare educators need to teach our students to focus on. So just a little bit of things that I immediately see that we can be doing as clinicians is really start to rely more on these structured or discrete data elements. That's going to get our documentation of our interventions, of our patient responses out in these big data sets faster. In the health system I'm in, they want to take the surgical notes, absolutely necessary, and do NLP on it. But we're seeing less of an uptake of them prioritizing things like our rehab notes. So again, we need to be at the table. It's great that the physician-driven knowledge is there. Absolutely, big improvement. But again, some of these other things that are in the electronic health record, if we're not advocating that they're also pulled in, then we're not going to see them pulled in as fast. I think we as clinicians need to be familiar with the idea of a standardized vocabulary. I think we've all gotten really good at using the ICF. We all know what IDC codes are, but there are also codes for drugs and procedures, your CPT-4 codes. And these are what often our billing people use to kind of categorize procedures. I think us being more familiar with them will allow us to extract data from these large data sets. And then I think my current bugaboo, and it's true amongst all of it, is that in the electronic health record, we have syndemics, right? That's disease-producing factors. That we're really good at documenting. What we're not so good at documenting are health-producing factors. Does the individual perhaps meditate or do yoga? Are there healthy practices they follow? Those have not been very deeply embedded in our electronic health records. Those are for people that are sick, perhaps. We are seeing that there's limited, and sorry, I used an acronym, social determinants of health. The neighborhood you live in, the air pollution factor, exposure to toxins, commuting, dangerous highways, all of that, race, ethnicity. But this too is also improving. Epic which is a big medical record provider, I think internationally, but it's certainly prevalent in the US. Has little widgets you can add into the electronic health record that will automatically prompt for a set of social determinants of health. There are ways you can map these massive big data sets on to each other, and we see that within our field of public health and epidemiology and our population informatic field where that's happening. So I'm going to switch a little bit and stay on this theme of words and natural language processing, because I think that's where a lot of our knowledge and our fear comes from. And so now we're moving into generative AI or Gen AI. And these use large language models, right? So their big data sets are on language. They're very complex. A lot of these processing units, if you will, a lot of clustering, a lot of supervised training. They set the weights based on whatever input characteristics the data have. And that's how they're going to generate speech recognition, things that we see like ChatGPT are going to be able to parse through that and come up with a sentence that almost sounds non-robotic. But these open source, well, let me come back. ChatGPT is proprietary software, right? It's put out by OpenAI. It by far is one of the most successful ones. It's integrated into Bing. That 9 should be an open parentheses. We're going to see what Gemini Ultra allows. Google Notebooks now has a proprietary large language model like ChatGPT. So just like Band-Aid is kind of the thing that you may put over a cut, ChatGPT, even though it's proprietary, we're using it often like within our lay language to mean large language models. So just to be clear on that. But open source large language models that you don't have to pay for, that are out in the internet, are also emerging. And just like anything that's not been put forth by big technology, they may be a little less user friendly. They may have a little bit more errors in them. But again, they're free. They're going to keep improving. How generative AI really impacts education and clinical reasoning, we're just really starting to figure out. ChatGPT was just released in November of 2022. So we've only really had a year of figuring out what it means when we start to rely on large language models to move from data information. So the new issues are going to continue. They're going to become old issues with ethics, the value and impact, both socially, economically, in our governance. And we're going to need to continue to explore it. And this is where I would focus a lot of our current education. It's not what's the latest version of ChatGPT today. It's really what is this ethical use of generative AI, moving up that pyramid. What is okay for it to tell us is, knowledge or wisdom, and what do we really need to be careful with? And do our students, do we understand the limitations of it making opinions, if you will, from things where really it was just aggregation effects? So the opinions that generative AI, the summaries it generates, are based on things that have already been decided in the past, right? They've gone through to see how other people have connected these things. So generative AI really isn't good at innovative if it's not in the data set, if there's not a clear connection between things, if there's not dual references to a phenomenon in multiple data sets, that if I had enough time as a human, I'd figure out. It's not going to generate necessarily new connections in its current form. So what is critical, again, is developing our Gen AI literacy. So be it technology, professional, academically, we can determine that we're going to use it responsibly, right? Companies can put it out there, but it's really up to the individual user to do what's right. We see this in our traffic laws. We have traffic laws, but people still can choose to drive on the opposite side of the street or not. That may be a bad example. When we initially talked to OpenAI in part of our National Academies of Science workshops, my question to them was, well, here, you're a for-profit company, which have to exist. You report to the stakeholders. So your job is to make money. And that's different than what I may do in my healthcare profession, which is to make people better. And that's fine. They exist in the world. But what are you doing to make sure that people are using OpenAI ethically? You guys are so far ahead of us in understanding what it can do. What are you providing us for guidance? And they said, well, that's not our job. Our job is we have the brightest people making these algorithms, making the technology available. That's what companies do. That's what, that's the way the world works. It's up to other individuals to put guidance on it. So they used the analogy of, there are a lot of people companies that produce weapons, guns. Here in the US, it's not the gun companies that have to make the regulations about how they're used. It's really up to society. It's up to individuals, and it's up to maybe the government to decide that. And they view this kind of as the same way, which when you look at how we've evolved over time, that's absolutely consistent with it. I think we have to have open-minded conversations about generative AI. I have colleagues at work that have said, I will not pay for, I will not allow my faculty, I will not allow my students to use ChatGPT. It is inherently evil. And, it's just, there is no conversation. And if we don't have open conversations, if we don't ask people, are you using it? Did you use it in the assignment? To give them a way to feel like they can say, yes, I did use it in my assignment, then I need to tell them how they need to let me know that, right? Because then I'm really grading two different things. Their use of a technology to form an opinion, and then whether they could form that opinion on their own at some point. So we need to be open-minded. I came to the table thinking the same thing that probably some of you did, that from a health educator standpoint, students using ChatGPT is just wrong. It's just, where's clinical reasoning going to go? Since then, I've appreciated the value of things like health bots, medical delivery systems in those, and I see that there's both really a lot of potential to make what we do in healthcare improved. And then there's also, again, still some of these scary parts. So at any rate, we need to provide clear and consistent guidelines. If we say absolutely not, then people may hide that they use it. We need to pivot our writing and clinical reasoning assignments to purposefully leverage the strengths of AI. We need to value the way it adds to what we do and what we're teaching. And we need to figure that out together. So thinking about, again, how to develop clinical reasoning skills now that generative AI is out there, just like handheld calculators and a variety of, cars, electricity, how are we going to use it? And we really need to start thinking about the quality of the assignments that move beyond just comparing, sorry, there's a typo in there, AI produced to that of what human produces, right? So I know a lot of people are like, well, I ask them to generate their own thoughts and then go use ChatGPT and then come back and tell me why it's different. Those are fantastic. It's a good way to start, but we're going to need to move beyond that. So examples of GPTs, just so you know, there's OpenAI's GPTs. They're custom versions. You can get the free version of ChatGPT in most places. You can pay a nominal fee, about $20 US a month, and then you can use ChatGPT to create specific tasks. So I have the ChatGPT, the full version, mostly so I can become literate in what it can do. And I can actually fine tune the data sources. Google's Notebook LM is just a little behind ChatGPT. You can actually give it a data set that you want it to make sense of, if you will, a written one. So you could, assuming you're within your copyright laws, provide it your library of articles on, I don't know, lab values in breast cancer diagnosis. And it can train on that data set. So that allows you to figure out, how do you deal with now knowing what that algorithm is trained on and limiting it to those sources that you consider viable. Part of this, and what I want to mention, I don't think I have it down in writing, it might have been in the resource list I sent earlier, is a GPT. It's not a ChatGPT, but I think it joined with an OpenAI called Consensus. So CONSENUS. What I like about Consensus, and I steer my students towards it, is it is actually based on scientific papers. So it's gone in and applied a large language model and trained it on actual scientific articles. So if you want to go in and ask it, what is the right rehab intervention for a frozen shoulder for a 50-year-old woman, it's going to already look at what's this curated data set, and it will return you may be a summary statement, but more important, it returns each and every reference it used in there. So the journal article citation with the journal impact factor. So if students are going to use a large language model to kind of help back up their thinking, looking at what's available now and steering them towards those that may already curate that data set that large language model is trained on is a really good way to go. So both the OpenAI will allow you to do specific tasks and use their trained large language model on a subset of data, so you have a little bit more control. A couple of interesting facts just about ChatGPT. If you use an emotional appeal in the prompt, it may actually perform better. And again, there's not a whole lot of data. These things are solid evidence, but people have found if, instead of saying I need a frozen shoulder rehab program, if you say, my mom's in terrible pain and she has a frozen shoulder, what should she do? What should the PT do? It may actually give you something that resonates a little better with you. They can be hacked, of course, as soon as you put a new software app out there, people try to play with it. I have not tried this, but I hear if you ask it to repeat a word an infinite number of times, at some point it will return, it will give you a little bit of an inside scoop on what it's doing. I don't know what happens, but somebody had mentioned that in a workshop I did last week. And it may, if you're not using ChatGPT, if you're using one of these other sources, if you tell it what would ChatGPT say, it actually also may perform better. So those are just kind of silly things that, as we're starting to play with this technology, we're figuring out, that amused me at least. So what is critical, again, is, I think I already put this slide up, so I'm going to skip over it. That's what happens when you talk so early in the morning. And I'm going to come back to some key points and what we need to do as healthcare professionals. My first question, and this should be no surprise to you, it probably popped in some of your minds. If we're using healthcare system data to train these models on, whether it's a large language model, whether it's a number-based model, if that data in the medical record is all over the place, one resident ticked off this box, the next two residents ticked off something higher on a Likert scale. So there's noise in the electronic health record. We didn't design electronic health records to be used to pull big data from. And so it's just flawed. Not everything's being extracted from the medical record. It's whatever is deemed important. And so how is that really going to help move us closer? And again, be it rehabilitation practice, be it clinical medicine, I think is something we need to think about. The other inherent flaw in only deriving clinical practice guidelines, if you will, from EHR data is that we see all the downside of people. We see all the disease, the syndemics, that at that level, that's going to give us bias. A lot of the healthcare data that we are also seeing be pulled in these models exists. And we already know that a lot of our large data sets, our health data, be it from in the US, our Center for Disease Control Studies, or other published studies, our All of Us data set, the Framingham Heart Study, were often done on people that met a certain sociodemographic characteristic. They may not be our rural, our people of color, our non, traditional European white background, and we're going to get very different answers that may not be appropriate for everyone. So again, that key point of look at the data source. So bots and chatbots, I had alluded to earlier, have a really neat role in healthcare. So we all know what bots are, and robocalls, right, are the most annoying thing. I'm assuming that you all get your
subset of automatic calls. Bots, robocalls for me are extremely annoying as a consumer, but for the company, it's brilliant because they can program, again, if it's a company about selling insurance, they only need 1 or 2 people maybe to buy insurance every hour for them to be profitable. So if they have a way of calling and interacting with people and making it sound like a real person, if they can do that 1 million times an hour and only 1 or 2 respond, then that's a brilliant technology for them. It's annoying to be on the other side. When we look at autonomous robots in healthcare, they may be able to deliver medication, again, assuming their input, what they're told to do is correct. They may realize when prescriptions, are at the wrong dose and not do it. But these medication delivery robots can take away, a nurse that may be needed at somebody's bedside, that these can do it automatically. Check-ins with individuals, more humanized care, in the US, I think in a lot of the world post-COVID, we're experiencing this wave of loneliness, especially in our elders. There's chatbots for mental health that really work. And so even though we would want a human interaction with many of these people, just having conversation, a meaningful conversation, a way to connect, can still improve their mental health when there really is nothing perhaps out in our rural region. So something to check in and have a basic conversation with sometimes is enough for people to feel that connection with the rest of the world when they're isolated. We've done an Alexa project. So Alexa, I believe, is an Amazon product. I don't use it, but it's, it's basically a speaker that hears what you're saying, and you can say, Alexa, play this song for me, or call someone. That's my rudimentary understanding of it. But in our Meals on Wheels program, which is a free program for elderly that can't cook on their own, where meals are delivered by a driver, healthy meals, one has it. We put a series of Alexa out in these individuals that were relatively isolated, and then wrote some programs where they could check in. So, your meal is going to be delivered today. How are you doing? And they could say, I feel short of breath. So we would train the driver to be able to do an O2 sat. They may say, I feel stressed today. And Alexa would say, do you want to try one of my stress reduction programs? We could meditate or do yoga together. And so it was able to meet some of those needs and identify, or with the person's input, identify. The person said, I feel just really lousy today, or I fell. It could say, do you want me to call 911? Do you want me to call your provider? So again, looking at ways that we can use things that are based on these large language models, this speech recognition, speech generation can be very thoughtfully crafted. So good bots, chat bots for mental health, for reconnecting, with doing some rote things like delivering medications. So when we look at the applications and how they're being used, it really comes down to, and I think for me, the scary part is who's driving the development of applications of AI in healthcare. It's not me, even though I'm an engineer. I can't develop technology fast enough. So it's generally clinicians may have an idea, researchers may have an idea, patients' healthcare systems may have, but it's really the AI tech firms that are going to be out at the forefront of new technology. I did a postdoc at MIT, which is an engineering school in the US. And I was very proud because I finally had my engineering PhD. But at lunchtime, I wasn't necessarily asked about my thoughts on the next engineering technology. It was always, Carole, we made a new machine. Could you come over at lunch and tell us if it has any clinical utility? And I thought, well, that's kind of backwards. You should have asked me first what kind of machine I'd want as a clinician in that situation, and then went out and made it. And so again, this is why we need to be at the table. We'll be welcome at the table. If you say, look, I'd like to give you an hour of my time. I have ideas about what should be used in patient care X and Y. If we keep making those offers, we'll be there. The other group that is starting to put a lot of money into AI things are healthcare insurers, right? So how can they have us see more patients cheaper and faster? And that's really a bad perspective on insurers. I shouldn't say that all health insurance companies want that, but it's to their benefit if they can move more people through the system as maybe for-profit healthcare systems. So it's something to think about. There's now AI apps that can be turned on during your clinical visit. And it will actually, for physicians in particular who it's targeted at, it can comb through the medical record, give you key points that you should ask. It can listen to your visit. It can generate a written summary of what you went over, and then you can read through it instead of generating it yourself, correct it, and put the note in. That could save 10 or 15 minutes per patient care visit. I would love to think that, especially with us at the table, we could say that's going to give us 10 or 15 minutes to connect with our patient. Some insurance companies or healthcare systems may say, well, now that you take half as much time to get through one of those clinic visits and check all the boxes, you can see twice as many patients. So again, it really depends on how it's being deployed, who's helping it be deployed, and really where do we want to advocate. So to me, that's what's scary. The apprehension of AI related technology is really who is the developer, who is implementing it, and what's their motivation. It's not the tools, it's not the applications themselves. It makes perfect sense when you look at this technology revolutions and cognitive transformations that this has evolved. AI tools are not inherently evil or good. It's really how we're using them. So challenges to implementation of AI technologies in clinic come back to the bias, the disparity. Are they interoperable across systems, governance, fair, trustable, transparency, this data set quality and availability, and how it impacts the infrastructure, the process, the workflow, and are we able to shift roles? So AI to look at your what's in your supply closet and notice when you're getting low on things and automatically ordering it is brilliant. If you don't need a human to go and do that, but you have a system to do that, then again, you've made the system more efficient. So again, there are good things about it. We just have to really be mindful about how it's used. So now let's focus a little bit on from the National Academies of Science. Again, what do health profession education leaders need to do to incorporate AI? So this is actually, it's a free paper from the National Academies of Medicine. It came out, and I'm going to walk through these. This is a really busy slide, so don't worry. But it's really the 8 concrete steps that health profession educators should really take now to make sure that we're doing the right thing. So the first is really educate yourself and faculty in basic concepts and controversies related to AI. So look at professional organizations in the US. Our Big Data to Knowledge program is a little bit older, but it has good things about aggregating data sets, looking at the quality of data sets. The Bridge to Artificial Intelligence started up about 2 years ago. Some really great free workshops on the basics of AI, on some technical AI. To me, the brilliant part about this is 2 things. One, they're looking for clinicians to become fellows. So one of my OT faculty members is one of the fellows learning about AI and being mentored through it. And that's free. I mean, you have to be selected, but that's free. And secondly, they're looking at introducing these salutogenic data sets. So broadening data sets that are available for these algorithms, for these AI to be trained on, so that we have less bias in the outcomes. The American Medical Informatics Association, again, has some nice things that are related to big data and machine learning. And many of those are free. And then again, this is the National Academy PDF you can download for free. That is available, that kind of does a deep dive into many of the topics I'm touching on today. And so there that is. It was published in 2019, so it's not going to give you the latest, greatest on ChatGPT, but it is going to talk about ways that they see AI helping improve patient and clinical team outcomes, and it's a good read. In 2019, this concept of deep medicine, how artificial intelligence can make healthcare human again, came out. I have just looked in the past week. There are more continuing ed courses. There's more courses. There are more free courses. There are more books. Everybody's writing on this topic. I don't think there's necessarily, this is kind of an entertaining book as well. There's not one source anymore. There's multiple sources. And I think as you pick and choose what you want to do, part of it is what's accessible, what students may read, what's not too technical, but what is really highlighting some of the ethical uses of it, and how we as individuals can make it better. So again, the first piece really is educating yourself and your faculty in basic concepts. In the last month, we're seeing books, 80 assignments using ChatGPT. And so I think faculty groups that use ChatGPT and work on developing assignments together is something inherent in the education system that really are emerging as ways. I think that's what my faculty are most worried about in my university, is what to do about ChatGPT. I do also want to mention that as you look through this, barriers and facilities, if you're more on how do we get AI adopted in the healthcare system, again, there's a perspective in the national academies that may be helpful, and that's what this graphic is. So how do we get healthcare providers to adopt AI? What are the things that we should consider? So I would point you there. The U.S. has a national strategic plan. I won't say a whole lot more about it. It's written very broadly. It really does look at governance and ethics across many things. I'm not necessarily saying the U.S. has gotten this right. Most of things that come up at the high government level sometimes can be a little bit fuzzy in terms of how they should be implemented, but it's another source, at least for people in the U.S. I have a feeling that several of, again, we're going to be outdated really fast. We have to move fast. So we need to build relationships with people that may not just be clinicians. So within our curriculum, we really need to start teaching ourselves how do we interact with our health system informatics and clinical decision support teams. If you are affiliated with a hospital system, to ask them, what AI applications are we using? If you're sending students out to various healthcare systems, what are you using for AI? What are you considering using? What do I need to prep my students to be ready for? How are you addressing AI adoption in the clinical system? Because again, if we're producing clinicians that are going to go out there, these are the types of questions that we want to know, so that we can either get them the training they need before, or we know at least what they're getting when they're out there. Talk to your computer science department at your university. Talk to the people that are implementing NLP on your medical records even. Ethicists have started to really explore this idea and have some great perspectives. Start a faculty and learner group across different departments that have an interest in this topic. We're all not, talk about big data, fast, variable, all over the place at a rapid rate. That's kind of the way AI technology is moving. And so the more people that we can engage in that are our trusted companions, that are like-minded, but maybe Your big thinkers are going to help get you forward. So again, that interprofessional education. So relationships and connections, while technology is moving really fast, is key. Look at a local advisory group, right? To collaborate with your existing curricular oversight. Invite somebody that is a local or regional expert in AI that's working for an AI company that may have developed the medication bot that you're using. Ask them to join or to look at your curriculum, or where do they see you needing to add things. So again, that outreach in both directions, us inserting ourselves where it's being used so we can teach our students, but also asking those that are developing that to also join at the table so they have a better understanding of where we're teaching. I think we need to be open about addressing skepticism about AI. I see more skeptics, at least in my community of healthcare educators, than I do understanding the promise. I've unwittingly or unintentionally become kind of an advocate for, wait a minute, there is some good about AI. Consider mechanisms that protect learners as we apply it to facilitating educational practices. So we'll talk about starting to embed AI. I was asked last week, can ChatGPT grade my students' assignments? That would save me a whole lot of time if I have written papers I need to have graded. And I thought, well, if you want something that's based on a whole lot of data collected from the world to grade your students' assignments, maybe, I don't know if I'd go there, maybe a rubric. But I think really when we look at assessment, to remember the inherent biases that are present in whatever data this has been trained on. We really need to make sure that learners understand that ChatGPT isn't giving you the best medical answer. It may be giving you the best answer generated across a variety of sources, including social media, that have existed for X amount of time before it could be trained and released. So it's outdated, it's getting faster. We're up to about a month turnaround now. But nonetheless, what are the data sources it's based on? If students use AI in one of my assignments, I ask them if they could put whatever AI wrote in quotes, and then they need to cite it just like they would do a reference. And they need to say, access ChatGPT 4 on January 17th, 2024 with this prompt. I could then go back and actually put that in ChatGPT. And as long as they haven't released a new trained model, I could see if that's, what it said, or where maybe the student needed prompting, saying, as I looked at the sources, I saw a lack of that. So I ask my students to just put it in quotes. You can't write your whole assignment that way. You have to generate something on your own. But when you use it, just let me know. Let's be honest about it. And that seems to work. 4, again, really comes back to looking at our outcomes in our curriculum. You should be having a discussion about where in your curriculum are you teaching AI, and that needs to happen now. Within my profession, physical therapy, within the US, we've just seen updated guidelines. These take so long to come out, right? It's for us, I think it's every 2 or 3 years. And now it says we have to include health informatics in there. It doesn't say AI, but we're embedding it in there. So we really need to look at what are some of the competencies needed. In that article that was written by Dr. Lomas, and again, it's in your references, it's in an earlier slide, they go through and talk about med school curriculum competencies within there in greater detail. And it's a great resource, especially for medical schools. The American Medical Association is a little bit further ahead of what they see as specific competencies for AI. I've covered many of them conceptually in this talk. Our related fields like occupational therapy, physical therapy, respiratory are a little bit further behind, but that's okay because our medical profession really has been, is a little ahead, so we can borrow from them. Consider incorporating AI learning objectives into any of your clinical reasoning assignments, assessing diagnostic errors, cognitive bias, your metacognition types of assignments, so those higher thinking ones, and identify potential opportunities for AI to assist in the administration of the curriculum. So, what are the current objectives in, I don't know, programs like mine within whatever part of the universe you want to look at? Can you compare that to mine? And it can come back and do that comparison, maybe that mapping from objectives to what it should be, from your department's output in scholarship, maybe to what's kind of the average that's out there. So really think about how you could use it at that tool, maybe not to generate knowledge like clinical reasoning, but to actually help make you running your curriculum administration more. Do want to mention that the International Professional Education Collaborative also has some objectives that could be included. And I just put this slide up there. That is their website. You can go and pull it. It kind of still talks a lot about the same types of themes that I'm bringing up here. And again, just a few other ones, looking at undergraduate training programs before they come into our healthcare education is one. So a couple of those points. Review the existing assessment programs. Look at your admissions. AI certainly could be, if you're sorting data, you have data on all these applicants and you want to sort it into like piles. You could say the people that get in and don't, or you could just say, what are the types of categories of applicants we have? So there's ways that you could use it for that. Participating in evaluation and research regarding the impact. Put question marks here because I want to leave you guys a little bit of space to explore that on your own. How do you compare yourself to other programs? How do you see, by embedding AI in your program, how you improve? And again, engage in national and global discussions about enhancing training, establishing learning objectives, leveraging AI, develop AI capabilities. Don't write it off as wrong, and I don't want to have anything to do with it. Write it off that I need to be engaged with it. So just a few final thoughts. We have to ensure that AI is built and used responsibly and ethically. So will companies self-regulate? We're starting to see a little bit of that emerge. Regulations, our efforts should really focus on the highest risk. We should include outcomes. We should try to provide durable outcomes and assessments of if it's being responsible and ethical, because it's changing so rapidly. And we really need to look across the globe, right? We're really interconnected. We all have different governments and different viewpoints and beliefs, but we are an interconnected world, and AI is going to transform us globally. We have to ensure that AI actually advances international competitives. And I would say healthcare security, when I think about it, is that, anytime we're fragmented and we have people that are really facile using a new technology and people that may not be so much, we start to see discrepancies and inequity. And so I think we really need to consider how we advance it, how we advance the policies so that it really is cohesive and it's connected and we're really using it for good. And again, that AI serves society broadly. It's not available to some people. We know there are continents and countries that barely have internet. So their data certainly isn't getting into any of our AI trained chatbots. A lot of the ChatGPT has been trained on data that's in the English language, so there's a bias there. And we just have to make sure that we're involved enough to make sure that AI really serves the people and the planet, and not just our individual needs or a insurance company's individual need or an AI tech company that's really, you know, beholden to making money and technology, and putting it out there and letting us kind of self-govern. So those are just a couple of final thoughts. I do want to close with this final thing. Again, I've talked about this information pyramid. Marvin Minsky is really considered one of the fathers of AI, has done an incredible amount of work early on. And what he really highlighted, and this is a man that really invested most of his learning to these tools in AI, and both the beauty and the peril. But what he pointed out was that what human level intelligence is really, it's not when it works, but when it's stuck. And if we're training AI on past data, you know, where is the innovation? Where is its ability to unstick itself? And that's just something to kind of think about. So I am going to close there. I'm going to stop sharing my screen and we can move into discussion for the last part of this. Sorry. All right.
Thank you, Carole. Thank you so much. I think we have some questions in the Q&A,
All right.
and then we can allow for discussion if anybody is interested. So there's a question from Prof. Frank. Should a modern medical curriculum contain AI training courses?
Yeah, I absolutely think it should. We are starting a certificate program within the University of Texas Medical Branch. I'd be more than glad to share some of the ideas of what an AI course should look like. Absolutely. It's not to teach the technical aspects again. It's really to teach the responsible ethics. How do you figure out what's available this week? Because it's going to be different than last week. The University of Michigan, Cornelius James, and I can put that in a response. And he's listed on a lot of the national academies. He's a physician that actually has a program called Data MD, where they're embedding a lot of this in there. And so that's another place that you could go and look for the types of courses you may want to do. So that was one question. As I look down, and thank you for putting questions in here, that ChatGPT-4 has a feature to export your own session. So you could use that as well. And I don't have a problem with that. Again, I think we need to make students realize that we do expect them to use ChatGPT, but we expect them to let us know when they use it and how they used it and what they prompted it with. And are they aware of the flaws in the data set and where the data came from? And so I don't know if that answers this person's question, but yeah, I'm fine with that. People are going to do it anyway. So it's like having a little kid that if they did something wrong and they're afraid to tell their parents, that's not as helpful as if they know that maybe they stepped over the line of what was right or what not to do, and they can come to their parents and tell them that. So that's my opinion. I don't know if that helps. And yes, and then there is an article in the Q&A that one of the individuals present had actually written. I will include that. Thank you for letting me know. Sorry, so I am reading sorry, I have to get close to my screen. I don't have my glasses and it's only 5 o'clock here in the morning. The question is how the medical and health field will look 20 years from now. AI, robotic surgeries, non-human doctors, where machines can diagnose and perform surgeries on human bodies. Yeah, you know, that's already happening. That we have a human doing it. We have robotic systems flying airplanes. So I don't know how I feel about that. I would still think I'd want a human to operate on me, but I wouldn't have a problem if there was a intelligent robot making sure that, I don't know, their hands didn't shake or do that. And we can have opinions on that. I think the medical field will look really different in 20 years. We look different in 20 years in respect to cell phones, right? They weren't here 20 years ago. I bet everybody in the room probably has their cell phone on, hopefully on silence. But I think that we are going to be changing, and we're not going to stop it. So we just need to figure how to move forward with it. Yeah, 20 years from now. Wow. So yeah, 20 years ago was the 2000s. So I think I had a cell phone. I expect that we will interact with a lot of the technology with voice, that it won't always be a physical interaction with it. We see some of that emerging now. I expect that a lot of our low-level things, delivering medications on time, room checks. You know, my mom had been sick last year, and she was lucky if the nurses would come by or an aide would come by more than once every 4 or 5 hours. I think that even if she had something that she could turn on or off with her voice, environmental controls, I think will be more common. I would love to think that we would still see and interact with our patients. So yeah, it's kind of frightening. But on the other hand, it could really allow us to spend that time with that personal connection and not. When we look at a lot of our younger generation, they all tend to interact with their devices already. Don't necessarily appreciate that. I often share it doesn't have anything to do with AI, but I was lecturing in a class live to about 60 students. So I'm up in front of the class. They all have their laptops open to the lecture, that notes I had put up there, and they're all looking at their computer. And finally, I'm like, hey guys, I'm up here, because they weren't even interacting with me, really. I didn't consider it. There wasn't really enough eye contact. So I think we are going to be in for a big change. I think those are the questions I see in the Q&A.
Yes, I think we can allow now for anybody who's interested to have
Yeah.
anything. Yeah, I
And
can see. Yeah, go ahead.
yep, I was just going to say in the chat, it does note that Notebook LM is currently only available in the US. And I'm sorry if some of the things I said were a little bit more focused in the US. That's just my bias. So sorry about that.
Yeah, it's fine. Prof. Fikri, please.
Yes, thank you very much, Prof. Tucker, for your excellent talk. I was wondering, actually, not only for education, even for medical writing, what's the ethical issues if you get a paper which has been actually been corrected by ChatB or whatever is that. But I mean, I'm from the old generation, and I used cards, 1981, to analyze the anatomy questions about their quality MCQ questions. And we've seen all this development. And I like to stress two important points of my career. 1987, we had a full week conference on anesthesiology, monitoring of anesthetized patients. And the final conclusion was that the best monitor was the doctor. And I remember also with Dr. Sami Shaban, if he's hearing, I think in 2003, there was a conference about health informatics. And one of the major strong recommendations that, for example, for doctors, they should be involved in the development of the technology, because the technology is just a tool and you should not be a slave of it. Now, I am a statistician, and I've been just interested for this because surgeons are interested in this, because, you know, in the operations, the color of the field, they can really know that there is a mistake, especially for, like example, what you've been describing in a nice way. And the important issue here is that how can we assure that the machine does not control us? We control the machine. I mean, we should tell it what to do. Now, for example, I'm a statistician, and then I get papers on artificial intelligence, and they are just a name. For example, they put 100 variables to predict mortality in trauma, and they get what we call ROC under the curve
Yep.
of 80 or 0.8, and then I directly reject the paper, and then I go to the until we say in statistics, I'm sorry for this, we say shit in, shit out, or rubbish in, rubbish out, because
Garbage
it
in,
depends.
garbage out. Yep.
Yeah, it depends on what's your data, and you look to the data. The quality is so poor. The class, they use continuous data as categorical data. So how can you develop a model if you change the fine one to non-fine one? And for example, we got much better with one variable properly prospectively collected. So the problem is not the technology. The problem, how can you assure that the data is good?
Right.
So
But that's exactly what we need to teach, right? That's the point of it
yeah. So
they're going to operate, but people have to understand how to evaluate those data sources. And if somebody returns something to you, you need to say what data. You don't have to ask which machine learning algorithm you used. You need to ask, what were your inputs to come up with that? And if they say,
and
I don't know,
Prof, to
that's
answer that, I'm actually supervising some research projects, and I get a hell of time to know where people got that data. So I
Yep.
prefer to read it myself, because health informatics is a key. You cannot now, in the huge amount of information, you cannot be a doctor without knowing where to go. So I prefer to get the source, analyze it myself, then depend on something which I'm not sure. I will end with 20 references and I don't know where is the source of it.
Yeah.
So yes, it will work as the computer does. If you put a proper SPSS program that is well designed, it will help you. But if the program is wrong, all your results will be wrong.
Right.
So
And that's the same thing. I mean, AI, machine learning, deep learning is just a tool. It really is in the interpretation and what data sources were used. And this is why I will actually openly say to my students, use consensus or curate a data set you're operating on. If you're using generic chat GPT and it's open source data, I'm not going to believe it. This is why we have peer review. Consensus will actually return every single source it uses. It was meant to be used for scientific and medical literature. And so I really steer my students to ask consensus at Chat GPT. Why did you get different answers and what's the utility? But yes, you are correct. It's a tool. It's not inherently evil. It's the data used, the interpretation, and the possibility that people feel they need to hide it.
yeah, I mean, I just will ask a question, because this is really will be a revolution, and we have to be careful. Now, one of the problems, even if you know how to critically read papers, I can tell you maybe 20% of the scientific papers published have some really scientific basic methodology. So if you use this, is there a way to critique the papers, the level of evidence, the analysis, the etc., using the AI, for example, when developing guidelines? Because we spent at least 2 years, as you mentioned, to develop a guideline with 100 people or 80 people reading and discussing. Can the machine do that? Is it possible for the machine
Well,
to?
but again, and this is where I think about the information. If you limit it to what data sources it can gather from, then you may have already influenced or taken away the bias of what it's operating on as data. But when it moves up, it should categorize that. It could do a better job than I. If there are 1,000 articles, it could more speedily group them for me. I need to check to see if that grouping is logical. If it's going to make interpretations from that, I need to know what the original data set is. So if somebody says ChatGPT generated this for me, even though ChatGPT you can ask, and next ones may allow you to see some of the data sources, we really need to steer them towards ones that aren't based just on some random data set that OpenAI had access to. So this is what we need to teach, I guess, is what I'm saying. Just like in statistics, they need to know the tools, but they need to know how to correctly apply it, and then how to correctly interpret the statistical findings in light of the potential weaknesses within the data set, and whether or not they applied the right tool.
Yeah.
So there is no easy answer, but this is what we need to teach. And your point about us being at the table to help guide and streamline, if ChatGPT heard that there is no physician, there is no healthcare worker that will use ChatGPT unless they can control, or if they have a medical ChatGPT that cites the scientific evidence, so I can evaluate whether I think those are relevant sources, then we just aren't going to use it.
Yeah, there are actually also very important. I'm just speaking because from developing countries, we know these problems. For example, the generalizability of the information. We did a study on acute appendicitis on 53 countries, and only 3 were from developing countries. So, this, that the developed countries, 90% of the information from there, while maybe the developing countries, they have only 10%. So how much this is relevant to our population is a major thing that have to be addressed. The other thing, which really I find it in research, the effect of companies on research. For example, people tend, once they write the health reports, to augment the disease so they can get more money. So I don't depend anymore on health records for data. If I do all my data prospective, because I know if I depend on the health system, they want to generate money, they will quote an injury severity of 1 into 5 because they want to get more money, and it affects the research. That's what my concern.
But those are concerns, and those were echoed in the discussion in the talk that I gave. This is why we need to be at the table. I don't think ChatGPT is what we need to be concerned about. The connectivity in the world, the inequities brought, in a lot of the large masses of data sets, so like Trinetics, that healthcare systems across the world are contributing. Brilliant data set, but if you look, hardly anybody on the continent of Africa is connecting their data sets in. So we are going to have biased data, but that's exactly what we need to teach. And what is the motivation for people that are developing and bringing these tools forward? So you're right. That's kind of the whole point of my talk is those are my concerns. Not the algorithms, but everything else around it. So thank you for those comments.
The other question, also I need your comments as an expert about how can you teach clinical reasoning using the AI? I think the clinical reasoning is a very, very high skill in which you really, it's not the pattern or the usual thing. It is when you see something unusual, you want to solve it. So this information would not be there anyway.
Right, because it's those unusual ones. I think we need to teach clinical reasoning, not using AI, but clinical reasoning, knowing people are using AI. So again, if you think about that pyramid I put in, clinical reasoning is really near the top. I think humans are going to be the best at it, that nuance, that intuition that most of us as excellent healthcare providers have. I think there's something to that. I think, though, the aggregation of facts, the number of times you go into a clinical room and you turn to the student and you said, well, I had you read the medical record. Can you give me a summary of the patient? Like, you're relying on a student to aggregate the facts to you. If you all would stand there and say, well, we used our medical record review tool to pull all sorts of things that were out of whack on this patient over their whole entire life, or whatever the electronic record has. Let's look at that and then go into the room. That may actually be helpful. And so again, I think this is why we just need to be at the table and we need to have those discussions.
Thank you very much. Really, I enjoyed the first part about the networking. I never understood it, but it was very clear today for me. Thank you very much.
Yeah.
Thank you so much.
Questions?
Any other questions? Oh, okay. Okay, thank you, Prof. Carole. I think we enjoyed this presentation, regardless the fact that it was full of IT words, but for clinicians, but was very nice. Thank you so much. And I would like
thank you for having me.
Yeah, we have you. Thank you. Thank you so much.
All right.
See you.
Have a good day, everyone. Good evening.
Yes. Please evaluate this webinar to get your CME hours. Thank you so much.